In 2013, Hollywood actress Angelina Jolie made headlines not for a new movie. No, she made news by revealing she had genetic testing that showed she was at a high risk of breast and ovarian cancer. The mother of 6 responded. She became part of a medical trend and decided to have both breasts removed in an effort to reduce the risk of cancer. Since then, she's also had her ovaries and fallopian tubes removed. In the past decade, doctors are seeing more and more women, some who, like Jolie, have a genetic mutation, choosing to remove healthy breasts instead of having breast-conserving surgery, even though both procedures offer the same odds of survival. To help us understand why, we turn to UCLA's director of the Breast Oncology Program, that's Dr. Sarah Hurvitz, and UCLA gynecological cancer surgeon, Dr. Sinez Amarzadeh. Difficult name, but she's really interesting. She conducts extensive research on ovarian cancer, and we want to welcome both of you to the broadcast. So this BRCA gene test, some might say it's a game changer instead of in terms of preventive care. How do you see it?
I think for the 5 to 10% of women who are affected by the BRCA gene mutation, it is a game changer because knowledge of carrying that mutation and the impact it can have on one's decision to do preventive therapy, such as Angelina Jolie did, is huge. Women who are diagnosed with a BRCA1 mutation have about a 55 to 65% chance of developing breast cancer at the age of 70, and for BRCA2, it's around 45 to 50%. So by removing both of her breasts before being diagnosed with breast cancer, she's reduced her risk by about 95% of having breast cancer. And Sanaz can talk to the risk-reducing surgery she had on her ovaries and the amount that reduced her risk of ovarian cancer, but I think it's huge.
Yes, I do agree that it is a game changer, and knowledge is power, basically, for women. It's important to know if a woman carries this genetic mutation. Particularly, I think it's important in the case of ovarian cancer because we unfortunately don't have early diagnostic tests. And because of that, majority of patients present with advanced disease. So if a woman knows about the fact that she carries the BRCA gene by having what we call prophylactic surgery, meaning removal of her ovaries and tubes before something happens, she significantly decreases that risk. And that risk is not negligible. In women who are BRCA1 carriers, by age 50, 21% have developed ovarian cancer. By age 80, 54%. In women who are carriers of BRCA2, which is in essence a sister gene, but less commonly mutated, by age 50, 2% have developed ovarian cancer, and by age 80, upwards of 27% of these patients have ovarian cancer. And considering that ovarian cancer to this day still to some extent is a lethal disease, this is important knowledge to have because you can do something about it with preventive surgery.
It's much more difficult to tackle once it gets, as you said, breast cancer, it seems like there's been advances. Ovarian cancer is still very, very difficult, correct?
Correct. So, and when we talk about ovarian cancer, there are many types of ovarian cancer, but the type that we're going to focus on today, because this is the type that the BRCA, patients who carry the BRCA gene are predisposed to, and it's the most common subtype, are epithelial ovarian cancers, account for 95% of all ovarian cancers. And yes, it's difficult to tackle. It's difficult to detect. Thus far, efforts in terms of trying to measure blood tests with the biomarker CA125 or doing ultrasounds together or independently has not been able to catch this problem early. As a result, majority of women who present with ovarian cancer already have stage 3 or 4 disease. And part of the challenge is that this very disease that we call ovarian cancer, we've learned recently actually does not start in the ovary. It starts in a neighboring organ, the fallopian tube. So to some extent, as doctors, we've also been looking in the wrong place. So a lot of knowledge has been emerging over the last few years about the origins of this disease. But I really hope, and I think that through our research and others, will help us get to the bottom of this and be able to detect it earlier and also treat it more effectively.
Well, I think that's really interesting what you were just saying, because the knowledge base, I mean, we've come so far as a society, and yet in many respects, there's still mysteries out there for the folks in your profession. Let me talk more a little bit about Angelina Angelina Jolie, though, in the respect that somebody like that writes something in the New York Times, gets a huge splash. You see all these stories on the news. It does raise awareness, but it also creates confusion, correct? I mean, what do both of you see?
In my own practice, and I treat primarily women who've already been diagnosed with breast cancer. So women who've already received a diagnosis of a pre-invasive cancer or an invasive cancer, and most of them have already made their decisions about what type of surgery they're going to have, and the vast majority do not carry a BRCA mutation. So what I saw in my own practice were a lot of phone calls and a lot of emails from these women concerned that their choice to have breast conserving surgery or lumpectomy may in some way have been detrimental to their long-term health. And that's absolutely not the case. So Angelina Jolie's decision to remove both of her breasts before being diagnosed with breast cancer was a primary preventive strategy, a way to prevent cancer from ever happening. And it did. 95% or greater chance has been lessened by that decision. For a woman who's been diagnosed with an early stage breast cancer in her breast, having the breast entirely removed or having both breasts removed does not improve survival compared to removing just a part of the breast that's affected by the tumor. And multiple studies have now shown this. So the Jolie effect, as we call it in the medical community, is that it has increased awareness. It's made women question whether they should be genetically tested, whether they should look at their own personal family history. So it's had very good benefits in raising awareness. On the other hand, for a woman who's already walked the path of having breast cancer and has gone through the decision-making process regarding what type of surgery she will have, it created a bit of confusion, which is our responsibility as physicians to sort of untangle for them.
Lots of emails, lots of phone calls. Breast cancer seems to get, there's a lot of cancers out there, and it seems like breast cancer gets a lot of attention. The cancer that you deal with on a daily basis, perhaps not as much. So in that respect, was it a blessing for you that you suddenly could be talking about another cancer, but also sorting through the confusion?
We're always talking about ovarian cancer. As an ovarian cancer surgeon and researcher, it's my responsibility to talk about it, and I owe it to my patients. And I do think that what happened in Angelina coming forth with this operation that she had actually opened a very positive dialogue in that respect. So here's the challenge. I mean, so in terms of her medical decision making, I think it's absolutely the right thing to do, what she did. And that's exactly how I counsel my patients. At this moment in time, because we don't have any good way of detecting these cancers earlier, a woman who carries a BRCA1 gene, the recommendations are that by age 40, she has removal of both ovaries and tubes. A woman who has a BRCA2 gene, by age 50, it's recommended to have this prophylactic surgery. Now, had we had better early detection tests, or if we had more effective treatments, perhaps that would not be the recommendation. But at this point in time, that is the recommendation.
Let's talk about mastectomies, because we've got a graphic that kind of illustrates there are various stages. So let's take the first one. Maybe we can talk a little bit about it, the different types, the preventive mastectomy. Talk to me about this, Sarah.
So prophylactic mastectomy is essentially, it's also called a total mastectomy, and it's essentially removing the breast and the nipple, but lymph nodes are not removed in general. In some situations, surgeons are offering women nipple sparing or and skin sparing prophylactic mastectomies, which allows a better cosmetic outcome in certain circumstances. So that's something that the surgeon and patient would discuss between themselves in terms of their risk-benefit ratio. A modified radical mastectomy is removing the breast and lymph nodes in the region, and that would be for women who have already been diagnosed with breast cancer in the breast, and typically it's offered to women who have a very large tumor, several separate tumors that are in different quadrants of the breast, but it doesn't remove the pectoralis muscle or all of the nodes in the region. So it's less deforming and less problematic down the line for patients who have that. This is in contrast to the radical mastectomy, which is shown on the top there, which was a traditional mastectomy that William Halsted pioneered in the 1800s. And this was done all the way through 1970. Actually, Betty Ford had a radical mastectomy, and that is where the pectoralis muscles were removed, all the lymph nodes were removed. The idea being that the only way for breast cancer to spread from the breast is by going through an organized pathway through the lymph nodes and onto other organs. If that were the case, then removing more of the breast tissue and surrounding tissues and all of the lymph nodes would improve survival. The problem was that Halsted never really looked at that in a scientific way and compared the outcomes of women who had lesser surgery. And that when that was ultimately done in the 50s and 60s by Bernie Fisher, it was shown that women who have an invasive cancer can have less surgery and a very similar or the same overall survival. And that's what led to the partial mastectomy or lumpectomy, breast-conserving surgery. There are multiple names for this procedure, in which the tumor itself is removed as well as an area of surrounding normal tissue, and the lymph nodes are sampled in the axilla or armpit region. So this allows a woman to save the majority of her breast. It's a less complicated procedure, it's an earlier recovery, and randomized clinical trials that have compared that versus the mastectomy has shown the exact same survival long term.
So do the patients ask a number of questions about this? Do you go over the range? What's that conversation like? Because of course it's jarring and they have to take some sort of action. It's a lot to take in.
These are very individualized or personalized discussions that are very important for the patient to have with her surgeon and oncology team in the beginning. And if the surgeon or oncologist is not giving the patient a lot of information, the patient should be asking questions. What is the size of the tumor? How disfiguring would it be for me to remove the tumor and save my breast? Is the tumor too big compared to my entire breast size to save my breast? Would you recommend mastectomy and why? So there are a lot of questions. And then also is important is reconstructive options, which should always be discussed at the same time as discussing a mastectomy.
She's talking about breast cancer in the different stages. Ovarian cancer, very different. Where do you see the research going to get us to the stage where perhaps we're talking about preventive measures and that sort of thing?
Right. Through our research, what we have found is something very interesting. In every patient tumor, and we analyzed patients who allowed us to take their tumor specimens and study it in the lab. In every patient tumor that we've analyzed, we have found that while majority of tumor cells respond very well to the traditional chemotherapy, there's a small subpopulation of tumor cells that are clearly resistant to the chemo. And they are resistant, and they're resistant from the very beginning, essentially. So in every tumor, there's a pre-existing population of resistant cancer cells. And what we've also learned is that while majority of the tumor cells express the CA-125 biomarker, which is the marker in the blood that we use to detect the cancer, this small subset is actually negative for CA-125. It has no CA-125 expression. So, but what's interesting we've also found is that not only the cell population is resistant to chemo, not only is it negative for the biomarker, but it also is a subpopulation of cells that very readily restarts the cancer. In essence, these are the cancer-initiating cells or the cancer stem cells. So what we learned in this study is that I think this is what's happening in clinical practice, that we treat patients with chemotherapy. In majority of patients, a small reservoir of these cells are left behind despite best efforts. And these are the cells that I think likely are responsible for restarting the cancer.
So you need to find the Achilles heel of that
Exactly.
once you attack that and figure out a way. But How far away are we from that?
We've done that. So we have recently done that in the laboratory, and we have very carefully profiled that cell population that is resistant to therapy. And through this work, we find some clear mechanisms that make them resistant to the traditional drug, which is carboplatin. Through analysis of this work in the lab, we find that in 50% of all comers, these cells sort of increase the amounts of an anti-death signal, basically. So chemotherapy is supposed to tell the cell, die, 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 die. But these cells have signals that allow them not to die and repair their DNA. So while most of the tumor cells die, these cells live on, basically. But there's a drug that can work, and it, I think, can work in up to 50% of patients with epithelial ovarian cancer who specifically have this death signal in their tumor. And we've, at least in the sort of preclinical models in the laboratory, what we learned is that if we combine this drug with traditional chemotherapy, now we can get rid of all the tumor cells, including the ones that were initially resistant to the standard treatment.
Sarah, one final question, because I think this is of interest, and I was just looking at the statistics. I want to get them right. In the U.S., the rate for those with early-stage breast cancers receiving mastectomies is right around 38%. The American College of Surgeons recommends no more than 50% of patients with early-stage breast cancer have mastectomies. But I was looking at Europe. The recommended cap there is 30%. Why this disparity?
Well, actually, these numbers are somewhat arbitrarily selected because there have not been good studies that have measured exactly what percentage of women should be having prophylactic mastectomies, period. So there aren't good metrics that say, in today's world, based on genomic profiling and what percentage of patients probably are at high risk of developing breast cancer, that percentage should be expected to have prophylactic mastectomies per se. So until we have good numbers or good metrics like that, it's hard to judge which number is closer to correct. That said, clinically speaking, in my practice, we are seeing way too many women choose mastectomy and contralateral prophylactic mastectomy who have no evidence that they're going to benefit from it. No strong family history of breast or ovarian cancer, no genetic background that would suggest a very high risk of breast cancer. And I think that the choice women are making to have more mastectomies in the U.S. and actually worldwide, but particularly in the U.S., is in many ways very fear-based. Patients are very afraid that breast cancer will come again in the opposite breast when they've already been diagnosed with breast cancer. I think there's some inappropriate assumptions that they're making regarding the fact that if they remove the other breast or remove both breasts, that this will improve survival. So it's important for patients to talk very carefully with their oncologists and their surgeons about whether or not mastectomy is necessary. And my sense, based on the statistics that have been coming out in the last 5 years, is that we're doing way too many in the U.S. right now.
It's fascinating. Thank you both. This has just been very enlightening, very, very interesting. And man, you're right there at the cutting edge. This is fantastic stuff. And you're getting out the warning to these women out there, and that's very important as well. Thank you both. Really appreciate it.
Thank you.